So now that we're going to get started, I want to go ahead and introduce our incredible sponsors today. I want to go ahead and start with Keith Woomer over at Global Litigation Consultants, who's been a great sponsor of ours. Keith, how are you doing?
Doing well. Thank you, Ginger.
Wonderful. If you don't mind, tell us a little bit about what you do at Global Litigation Consultants and then what you guys offer.
Okay, well, I'm a business development consultant with Global Litigation Consultants, and I work with clients to find them solutions to their litigation issues, both litigation and financial issues that they come across. We have a great team of in-house nurses that provide anything from a brief merit evaluation to a more in-depth case analysis. Then on the settlement side of things, we do benefit compliance and special needs trust, as well as a suite of other services to help you with those issues.
Wonderful. And I know that you guys, I think you work with TBI cases and clients. How do you guys work with them though? Tell us a little bit more about that.
Well, so yeah, we work with a fair amount of TBI cases in different capacities. So some of the cases will find experts, some of them will do the case analysis, and then we also do life care plans for a lot of those cases. And I think those really add value to the case. The attorneys that we work with on those really seem to enjoy that work product.
Fantastic. Well, thank you so much again for joining us today. I'm going to make sure everybody gets a copy of your contact information after the webinar. Okay?
I appreciate it. Thanks for having us.
All right. Take care. Thanks, Keith. And then now it is my pleasure to introduce Paul Luttrell, who's the owner of Strategic Relationships. Paul has been with us for years, and he's been wonderful. He actually lives in Atlanta, Georgia. And Paul, thank you so much for being here. If you don't mind, let us know a little bit about what you do.
Sure, and thank you, Ginger. So I own Strategic Relationships. Here's how one of our law clients recently described what happened in their case once we intervened in one of their TBI cases. Our client said that we connected them to a remarkably well-informed corporate insider, a former crashworthiness team manager of their defendant automaker. And this person was able to reveal test results that the defendant did not publish. In fact, they hid those test results. They also helped our client write their interrogatories all their way to a great settlement. So it's no big shock that defendants aren't always honest, right? And sometimes they hold these secrets back from the court, secrets about their misconduct and the negligence which caused the client's injury or death in the first place. So here's the question. Who is best poised to tear the cover off the cover up? And the answer is your defendant's ex-employees. Now, those who are knowledgeable, they're no longer beholden to that company, and not necessarily the ones you're getting out of discovery, but the ones your defendant is hiding. Those are the ones that we are skilled at harvesting and bringing them to you. We call them whistleblowers. So we've been connecting trial lawyers to whistleblowers for about 18 years. And you can ask Mark Lanier or Tom Girardi or Bob Clifford or Don Keenan here in Atlanta. They'll tell you the same thing about our record of success. So whether it could be a zip line injury, it could be a bed sore case, it could be a trucking tragedy, a burn, a drowning, a dram shop death, or an assault on private property. It doesn't matter to us. If it's a corporate defendant who's hiding the ball about their culpability, we'll find those people who can turn your defendant inside out. And I'll make sure to put Laura's information on there. Laura will get you on the bullet train to your next whistleblower.
Absolutely. And doesn't John Romano call you the $1 Million Man? There's a story behind that.
I think that's Eric Hertz.
Oh, that's Eric Hertz.
Ambrose calls me the whistleblower whisperer. I kind of like him.
Well, thank you so much for being with us,
Thank
Paul.
you.
And like I said, I can't wait to bring Laura back in at the end of the webinar because you guys are going to be announcing a lucky winner on this webinar, and they're going to get $250 to go towards one of these wonderful ex-employee lists or other lists that you guys have. So thank you for doing that giveaway, and I cannot wait to bring her back in later.
Thank you.
And now I'm so excited because we're gonna go ahead and get this webinar started. And I wanted to let you guys know that if you have any questions, please go ahead and look at the bottom of your screen right now, and you're gonna see a Q&A box. You can write your questions in there. And Hali, who is our wonderful moderator, she is gonna ask those questions throughout the webinar. And now it's my pleasure to go ahead and introduce Hali, who is wonderful. She actually works with John Romano out of the Romano Law Group down in West Palm Beach. And she concentrates a lot of her practice on a variety of personal injury matters, wrongful death cases, and product liability litigation. She earned her Juris Doctorate from the Florida Coastal School of Law in Jacksonville, Florida, and her Bachelor's of Business Administration from Stetson University, which is wonderful. And Hali also worked as a law clerk for the Office of the State Attorney for the 19th Judicial Circuit in Fort Pierce, Florida, and at the Guardian Ad Litem program in Port St. Lucie, Florida as well, while she was attending law school. She served as a law clerk for the Romano Law Group, which is amazing because she did all this and then became a wonderful trial lawyer. But during her summer prior to graduation from the Florida Coastal School of Law. And additionally, Hali was also certified legal intern for the Office of the State Attorney for the 7th Judicial Circuit. And I hope I say this right. Is it Patalayka, Florida, Hali?
No, that works.
That's okay. And I know that you worked on several felony and misdemeanor cases during your final year of law school there as well. And also as a student, you were selected as a member of the nationally recognized Moot Court Honor Board, and you've earned multiple Dean's List awards as well. So thank you so much for everything that you do, and we're so excited to have you present our webinar today.
Thank you so much, Ginger. We have a wonderful program for you today. This is part 4 of our 12-part TBI series. So our panel today is going to be discussing with you neuroimaging, how to get the best evidence for your TBI case. We're going to be discussing an array of neuroimaging tools that are available to help prove the TBI cases, how to get these things into evidence, and how to deal with expert challenges in court. The panelists today are also going to discuss with you that this isn't junk science, how to pay for it, why you need a high quality database of past scans for comparison, and why it's not a silver bullet, but it is an important part of your TBI puzzle. As Ginger mentioned, today we're going to do things a little bit differently than we normally do. We're going to take questions throughout the presentation, so please utilize your Q&A box at the bottom of your screen, and I will facilitate those. So without further ado, I want to go ahead and move into the introduction of each of our speakers so that we can get started on this very important topic. First, we have Hugo Chanez. He is a partner at Mitchell Sanchez in New Orleans, Louisiana. He has practiced law all over the world. Currently, he focuses his national practice prosecuting traumatic brain injury cases. He is a fellow of the American Board of Trial Advocates program at Harvard Law School and a part of the National Trial Lawyers Top 40 Under 40. We also have with us today Dr. Travis Snyder. Dr. Snyder is a neuroradiologist specialist with SimonMed Imaging in Las Vegas, Nevada. He is also a current assistant adjunct professor of radiology and neuroradiology at Touro University of Nevada Osteopathic Medical School. In 2019, Dr. Snyder was recognized as a Vegas Healthcare Quarterly Top Doctor in Radiology. He has a special interest in teaching rotating medical students, lecturing, and research on advanced imaging techniques for traumatic brain injury and carbon monoxide poisoning. And lastly, but certainly not least, we have Kyle Kinberger. Kyle is a national sales manager for HMR, an industry leader in medical funding. A lot of you have probably met Kyle. He's with us a lot, and it's just wonderful. He has helped hundreds of attorneys get necessary funds for their clients' medical care, and he currently oversees the daily operation of business done in the 39 states where HMR currently operates. And with that, Kyle, I'll pass it to you to get us started today.
Thanks so much, everybody. I think that this is a great opportunity. You know, the last webinar series we did where Hugo and I had a chance to really get into our first TBI series, we started addressing things with a physiatrist there, Dr. Susan Swent. And a big part of what came out of that and the questions that came from it were that TBI as a whole was, a puzzle where we're putting various pieces together. And so whether it was, a physiatrist or a neurologist or, something like neuroimaging or neuropsychological testing, it all fits as part of this puzzle when it comes to TBI. And so, for our portion of it, when Hugo and I were kind of discussing things afterwards, he brought up Dr. Snyder and just the work that he does and how it kind of builds upon that puzzle when you're talking about traumatic brain injury cases. And so, for our portion of it, we are always trying to give, attorneys these types of resources around the country, because what we've found is with these kind of catastrophic injuries where people need these kind of services and need this kind of treatment, they're not limited to, the state where they live or the city where they live. They want the best, treatment that they can get. And so when you talk about, the work that Dr. Snyder does and what he brings to the table when we're talking about advanced neuroimaging, which usually is a very hot topic when we're talking about traumatic brain injuries. It's great that Hugo was able to bring Dr. Snyder to the table today. So a lot of the questions that we end up getting, when we're funding cases around the country for traumatic brain injury revolves around advanced neuroimaging and when to bring it in and, who should read and what are the implications. And so, because we were fielding so many questions like that from, attorneys around the country, we thought that this was a great installment to this series. And so I know most people didn't tune in to hear me talk. So I'm gonna turn it over to Hugo, who you did a great introduction for, and let him take it away.
Thank you, Haley. Thank you, Kyle. So yes, so what we're talking about last time is that these mild TBIs are really invisible injuries. So how do you prove it to a jury? Because the only way you're going to get top dollar in either trial or settlement is by showing the defense that you're going to get it at trial. If I'm going to take your lunch money no matter what, you might as well just pay it up early. So when you have this invisible injury, you got to be able to show the jury something. It's the whole adage of seeing is believing. And that is where neuroimaging comes in. And a lot of times people say, well, DTI sounds very kind of fancy and looks really cool on screens, but DTI is only one part of all the tools you can use when it comes to neuroimaging. Now, I want to caution everybody, neuroimaging is not going to prove your traumatic brain injury. You can't simply rely on that. As we've always mentioned, it's part of a puzzle, but you do need to work with a very, very well-qualified neuroradiologist who can sit down with you and explain to you what actual part of neuroimaging you need to use and best fits your case. Not all cases are the same. In some, you may use DTI. In some, you may use spectroscopy. In some, you may use volumetrics. So when these issues arise, we always look for somebody who's really well versed on the issues and can sit down and parse things out and explain them out to a jury and explain them out to lawyers as well as to why we're not going with this DTI that sounds so hot and everybody's talking about. Why are we going with this instead? And that's when we work with people like Dr. Snyder. So Dr. Snyder, do you want to give us your introduction to TBI and the concussion protocols?
Sure. So thanks everyone. Thanks Haley and Kyle and Ginger and especially Hugo, who I've worked with quite a bit over the years. So I guess I'll start the lecture and see if I can't share my screen here without any issues. So hopefully everyone can see this. I see some head nods. Okay, good. All right, so we'll get started here. So I work for SimonMed Imaging. I also am the radiology program director at Mountain View Hospital, and then I work a lot with Torrey University, Nevada. In fact, I have three students to my left as we speak who are also watching this. And then also thanks to the moderators here. And so this lecture is on imaging findings in traumatic brain injury, and we'll get started. So this is kind of the outline of this lecture, and there's a lot to cover here, so I'll try to kind of move through it. And at the end, of course, welcome to share this with anyone watching. It's a, as far as I'm concerned, a public document. There's nothing in here that is, I don't mind sharing. So the outline lecture, first, as Hugo was saying, we'll start with the optimal TBI protocol. And I kind of started with this because instead of jumping into the findings, because if you don't have the right protocol to look at the brain and traumatic brain injury, then it doesn't matter, how much you know about traumatic brain injury or how great of a radiologist you are, you're not going to be able to make the findings. So kind of broke it down into standard protocol and then our advanced imaging. And the next part of the lecture, we'll talk about imaging findings, which are highly specific for head trauma. And these are ones that, there's not really any debate about. Everyone agrees that they're specific for head trauma, but we'll talk about those because some of them have prognostic implications that you can add value as a radiologist when you can discuss. Then we'll talk about imaging findings possibly related to head trauma. And a lot of times the findings here are sometimes it's not, you can't really say as a radiologist, it's more likely than not. Sometimes you might, but a lot of times you can't. But we'll talk about those because if they have the proper clinical symptoms, they actually can be from the trauma. And I've dealt with quite a few cases where that ends up being the primary focus of the the litigation or of the patient's symptoms. But we'll spend most time, probably, time permitting, on imaging findings which are more likely related to head trauma. And this is where there's lots of, there's debate and people have different opinions on. So that's why I think it's probably the most interesting. And we'll break that down to atrophy. We'll talk about volumetrics and things to look for, not just volumetric, but subjectively from a neuroradiologist just looking at the images. And those would be mostly hippocampal, cortical, and then lateral ventricle size. And then we'll talk about white matter shearing and last diffuser tensor imaging, which is a quite exciting topic. We could probably do a whole hour on that. So we'll start about the TBI protocol, and the first line of assessment most of the time for TBI protocol, especially more severe cases, is a CT. And so the patient has an MVC or an assault or whatever the trauma is, and they go to the ER sometimes, and not all the time. But if they go to the ER and they get a CT, and CT is really done to assess for life-threatening conditions. It's not to diagnose mild traumatic brain injury. You can pick up bleeds, fractures, midline shifts. And these are just some examples. These are axial CT images showing subdural hematoma and some subarachnoid hemorrhage and some intraparenchymal hemorrhages. So the value of CT, as we said, it's essentially non-diagnostic for mild traumatic brain injury. It doesn't have the resolution to pick up findings in mild traumatic brain injury unless it's one of those life-threatening conditions. But one of the things that it is of value for is soft tissue swelling and scalp swelling to show where the direct impact site was. So there's swelling over the forehead or in the back. And a lot of times that can be missed by radiologists. And the reason they miss it is because it's not going to impact the care of the patient. So if you have a busy list and you're reading 50 studies and you're flying through it, you're looking for those life-threatening things that they were scanned for. And the soft tissue swelling, you have to go very slow and you have to look at many different planes, and so it can be missed. And so that I think is an important finding because sometimes in some of these cases I've been involved with where it's denied that the patient even had a head trauma. People say they didn't even hit their head. And it's all in the record, but other experts or other people that I'm working with say that it didn't happen. So when you can prove it on CT, it does add something.
And Dr. Snyder, can I interrupt you there for a second? Because
Yes.
that point is critical. Often enough as lawyers, we get a client says, yeah, I hit my head, but I broke my ribs too, or a bunch of stuff that happened. And when I got to the hospital, I didn't tell them I hit my head. I had broken ribs, I had a broken leg, all these other things. And the defense always latches onto, well, did you complain about head injury? Did anybody look at your head? I mean, the typical medical record is going to say a traumatic head, which would say no bumps. You didn't even hit your head. When we can take these films and get somebody like Dr. Snyder involved and they can find the swelling from day one, it proves the location of the injury. And that is critical in a lot of these cases where we have to prove that there was an outside injury to the brain to begin with.
Yeah.
I wanted to, and Dr. Snyder, I wanted you to kind of add a point to it. You know, a lot of cases that we see that come in for traumatic brain injury, you know, inevitably it's an ER record that shows the patient had a CT of the head and it's normal. And you have a lot of people who get these kind of cases and they go, well, I've got a normal CT. There, you know, I'm kind of stuck, or there must not be something going on. So this kind of seems to speak to that.
Yeah, in fact, the same is actually true for MRI. And I think I'll talk about that later in the lecture, but MRI also is quite insensitive to mild, we're talking about mild traumatic brain injury. And so there's some, I mean, I've heard some neuroradiologists that say MRI is normal means the patient could not have a traumatic brain injury, which is of course blatantly incorrect. And that's that's opinion that's way outside the medical literature, but it's opinion that you know, sometimes you should run across.
So the other, ask you one question from the audience. One of our attendees asked, does there have to be head trauma to sustain a TBI? Meaning, does there have to be blunt trauma?
Oh, no, that's a good question, and certainly not. Whiplash injury is a well-known cause of head trauma. I mean, we see this there's a lot of the literature on TBI because of the funding from it is based on military studies, and they're blast studies. And these are blast studies where the patient didn't hit their head at all. It was just a blast that went off near. And so whiplash is a common, or even if there's a directional change in for example, a car, you can get shearing injuries without actually hitting your head. Now, you know, of course, some of the more severe traumas we see do involve, you know, fractures and hitting the head, but it certainly does not have to be. So the other value of CT is that some findings on the CT will resolve by the time MRI is performed. And there's been cases where there actually has been subarachnoid hemorrhage or subdural hemorrhages, which have not been, you know, either called or described properly, you know, when I look at the case. And you don't see it on MRI. You cannot see it on MRI because those tend to resolve, but there's quite significant prognostic implications on those findings. So this is all a reason not to ignore CT. You know, don't just jump to MRI and think that's the whole thing and going to do all this stuff. So CT is important. All right. So, and this is just we already talked about this. This is an example of a case, and the reason I show this case is because none of this was actually called by the radiologist, and it was denied. The patient had a head trauma in this particular case. So here we see. This was the 2613 CT actual image. This is the left, and there's some soft tissue swelling here showing the direct impact site just under the skull by the outer table and then under the scalp. And they had a follow-up because they were still having symptoms, and you can see that it resolved a little, but it's still there. And then a year later, they had this CT, and it was almost completely resolved. In fact, it did completely resolve. So this is unequivocal that there was a soft tissue swelling. And you know what we can do with this, just for presentation for a jury or arbitrator or for whoever, we can show zoomed up images with arrows and kind of show this in a very clear way where there's no question that anyone who looks at this, including any radiologist, will admit that this is here and that this was the trauma of the patient, which more or less healed on follow-up. So that's an example. So this is if they have subdural or subarachnoid hemorrhage, and those are, we don't have to get into what those hemorrhages are or where they are, but they're different spaces, not in the brain, but they're outside the brain. And there's various spaces that exist outside the brain, and these are subdural and subarachnoid hemorrhages. And so these are examples here. This is a subdural hemorrhage, and this is a subdural hemorrhage on the sagittal or a side view on MRI, and this is the subarachnoid hemorrhage going into the sulci here anteriorly. And this is a CT showing subarachnoid hemorrhage, which is a little bit subtle here in the anterior falx and the anterior frontal lobes. And the important thing, so it's good to identify these as radiologists, and then a lot of times I will talk about these things because they have prognostic implications. Where both of these have fairly high mortality, which means death, but they also have morbidity. And so they talk about, these are the articles which talk about these functional recovery rates from, this is surgically treated, subdural hematomas. And 25%, it talks about 50% of survivors have personality changes and subarachnoid hemorrhage and all this. So you see it on the initial CT, and then it will resolve on the prior MRI. But it doesn't mean, sometimes people might say, well, it's resolved, so they're healed, they're fine. But there's significant prognostic implications, and those are the articles that talk about it. So now we're going to kind of get into the main part of this, is the TBI protocol for MRI, and really is the only way to completely assess prognosis and full extended damage. And the good thing about it is it can be done, as an outpatient, and there's many as outpatient. And sometimes they do these in the emergency room as well, and I kind of look at those if they're available. But a lot of times their protocols are not very good in the emergency room. They're really looking for life-threatening stuff. They don't do some of these, some of the best sequences or the advanced sequences. So here's the optimal MRI protocol. This is our protocol at SimonMed, and we have different kind of tiers of this. We can put some of this on the lean. We have an advanced protocol, which is like a cache. And so it just depends on what the interest is and that kind of thing, and also what the resources available. But from a medical point of view, we'll just talk about that. But so the standard imaging, and this is just standard MRI sequences that are done. And so the best would be on a 3 Tesla magnet, and you can think of it as a better camera lens. So with a 3 Tesla, it means it's a higher magnetic field, and the images are crisper and cleaner. And 3 Tesla is the best. There's 1.5, 1.0. If you get, and some of the other ones almost become non-diagnostic if you get to a certain magnet strength. And SWI stands for susceptibility weighted imaging, and this is the optimal sequence for hemorrhage. And this is in red because it's the most important imaging most important sequence that you can do in a traumatic brain injury case. Or even as a clinician to order. And if you don't do this, it's really not benefiting, and you're going to miss a lot of things. So this is if you had to pick one sequence, it would be this to do. And it's a lot of these sequences are a little bit expensive in terms of from a imaging standpoint, because you have to unlock the MRIs, you have to pay the vendors like GE, a certain amount and all this. So a lot of places don't have it because it's of the expense. And then you want to do thin section triplane imaging. And so that means if you go to the emergency room, they'll scan you axial top to bottom, and that's it. So, but then you're going to miss stuff because there's 5 millimeter slices, and we'll talk about that. But you want to do ideally axial, and then sagittal, and also coronal. So front to back, left to right, top to bottom, and then you'll see these subtle contusions. You'll see the shearing injuries with a lot greater detail. And there's so many cases where they did not get this thin section triplane, and things were missed that we pick up at our centers, or that I see from other places that other centers are do and pick up. And so then advanced imaging. And so these are the advanced imaging that we do that I think are beneficial in traumatic brain injury. Volumetric software, because it can show atrophy, and atrophy means injury, means the structure in the brain got smaller because it was injured. Brain doesn't heal, damage is permanent. A diffuser tensor imaging, which looks at white matter tract damage. Perfusion looks at blood flow, and this can be contrasted, or there's called arterial spin labeling, which is non-contrasted. And there's some other ones too. MRA, you can look for, looks at vessels, so you can look for any traumatic aneurysms. Or if there's a question of whether the patient has vascular disease that could have caused some of the brain findings, you can exclude at least large vessel vascular disease by MRA. Spectroscopy looks at micrometabolites in the brain, and this is actually very interesting for traumatic brain injury. And then functional fMRI, we do auditory at our centers, but there's other ones that can be done. So time and cost constraints, that's the issue on what protocol that would best benefit the patient, or in terms of if attorneys are involved, then that becomes an issue of how much value there is in the case, and whether they want to do all that.
Dr. Snyder, we have another question that came in from one of our viewers, and she would like to know, how long after the loss would atrophy appear on a study? Is it something that would appear immediately?
Yeah, so I think we'll actually cover that later in this a little bit, but yeah, atrophy begins almost immediately. First, the brain will swell a little if it's severely injured, and you'll have some swelling. So using the volumetric software, looking at things, the atrophy will start to begin very soon. Neurons will start to die, and then the atrophy will accelerate in the 3 weeks following the trauma. in the first couple of weeks, and then in the 3 months it'll be still going on, and then it'll stabilize a lot of times around 6 months, but it may continue after that. And in some patients that have a sort of a inflammatory response, it can even continue years, and it's called accelerating aging. So a lot of times, imaging, you can't date when trauma occurs, but if there's volumetric loss, you actually can. I mean, not to the day, but you can say it was, that this was from a trauma that was in the, in the past, a given time frame, a couple months or whatever. So that's a good question.
Dr. Snyder, I wanted to ask your opinion on something. So, as we work a lot of these cases, we'll have attorneys come to us to talk about cost constraints to fund a lot of this DTI type imaging, advanced neuroimaging. And so some of the requests that we see come in, are people from relatively small towns, or they're not in big, metropolitan areas. And so they'll say, hey, I've got, somebody who can do a DTI scan, but it's a 1.5 magnet, or a 1 Tesla or something like that. I'm curious your opinion on advanced imaging as it relates to the strength of the magnet and how that affects the overall imaging that's done.
Right. Yeah. So the 3 Tesla magnet is going to be better for all that stuff. And there are some centers, that I know are doing diffuser tensor imaging, and they sort of get criticized. And I think a lot of some of the stuff that we, that we see where DTI tries to be excluded, and there's statements done by different groups, is because of these smaller centers that are doing this without much experience and without the proper DTI protocol. I don't think I discussed this in this lecture, but DTI, you look at it from different directions that water moves. So, we do it in 33 directions, which is what a lot of the literature is, but there's some places that do it with 16 directions or even 4 directions, and it just creates a lot of artifact. And so when people try to draw conclusions for those, it sort of hurts the people that are doing it the proper way, in my opinion. So I think it's best to use an ideal protocol using high field strength magnet. If you can, or if you don't have that, then to have the experience and to have the knowledge of diffuser temperature imaging to do a protocol in the right way, so it doesn't get criticized or thrown out, or to make it scientific, basically.
Sure.
Kyle, if I can kind of jump in on that.
Sure.
Most of the times you're going to deal with a Daubert issue on this, especially if your neuroimaging is really helpful, they're going to want to knock it out. So the more scientific your work is, when Dr. Snyder can say that he followed a protocol that is accepted in the medical literature, that he did the DTI inspecting on 33 points as the medical literature is required, it's a lot easier to get past that Daubert challenge than it is when they say, well, the literature requires 33, I only did 4, but that's acceptable. So that's why the importance of the protocol is you have somebody who's got sound specifics that mirror the medical literature on that, so that when you face that Daubert challenge, or when you're expert in the cross-examination, he can show the validity of his study.
Understood.
Yeah, I agree with that. Okay, so why advanced imaging? This goes back to the question, I think, from the audience we had before, is that conventional imaging, conventional MRI, is actually very insensitive for traumatic brain injury, with only 27% of patients demonstrating imaging findings. And this was by you in 2013. So that's a pretty significant number. And so if someone says the MRI is negative, therefore they cannot have a brain injury, you can show them that article, and they should know that. And there's other ones too, but this was a pretty nicely done one. So because of that, therefore, the conclusion from that is that advanced imaging is indicated in many cases, which is more sensitive and can identify pathology not present on conventional images. And this was the article. This was actually my article, or our article in our group that we just published recently, which talked about this. And well, we'll talk about our article later. But that it showed that that it has prognostic implication. Advanced imaging has prognostic implications when conventional imaging is normal. That's what. And then this is a great book. Osborne, Dr. Ann Osborne is very famous neuroradiologist. She's extremely well published. She's the chairman of radiology department of Utah, which is right next door here in Nevada. And this is her book called Osborne's Brain. And this is kind of like the, if you want to call it the Bible of neuroradiology fellowship. Like when I did my neuroradiology fellowship, you know, we would go through like chapters of her book. And there's many, every medical specialty has a book like that to some extent. And so this is her book, and it's considered like a standard. And in this book, she talks about advanced imaging a lot. So sometimes people say that it's not, you know, it's not indicated or it's not, you know, valid or whatever. But I mean, this is the textbook for neuroradiology fellowship. And there's so many examples in there where she discusses advanced imaging and the benefits and what the research shows on. So anyway, those are some resources I think can be helpful. So I'll go through some of this. So susceptibility weighted sequence, that's what we talked about before, the gold standard for hemorrhages in the brain. And it's actually 4 to 6 times superior to gradient echo, which is a different type of cheaper MRI sequence, which is probably more commonly done. And this is an example. This is just from the internet showing a normal brain on GRE. And you do the SWI and look at all these hemorrhages. So this is why you need SWI. Here's a case from.
What is the cost of SWI? Someone wants to know.
It's not a cost for attorney. It's a cost for imaging centers. Yeah, the imaging centers have to pay the manufacturers to unlock that sequence, but it's not. I guess in a sense it would probably be passed on to the attorneys, but it's not an. You know, at our centers, it's not an extra cost. It's just part of the standard. It's considered part of the sequence. Is part of just the standard cost of the brain. It's not a. You don't have to order this extra. Any patient that has traumatic brain injury. In litigation or not, or workers' comp, or anyone that has head trauma, our techs know to run SWI because for the patient. I mean, so they do on everyone. So here's a case of in our centers where this is an actual image of a gradient echo. And you know the arrows are on this now, so it looks very obvious. But this was actually missed by a radiologist. And when you're scrolling through this and you don't window it, I windowed this just. Windowing means when you adjust the screen so you can see things better. I windowed this just perfectly for this presentation. But if you don't window this, it really almost looks like a vessel. And it was a very subtle finding. It was missed. And then we did the follow-up. The patient kept having symptoms. They came back. We did SWI. And then we saw all these hemorrhage there. There's no differential for this. This is hemorrhagic diffuse axonal injury. And it is you know, shown by that. And here's the article that shows how much better this is than that. And now what some people may not know is that all SWI is not created equal. So there's SWI technique, which can optimize the SWI. So just because you have SWI doesn't mean you have the best SWI. So you want to do thin section. You can make these as thick or as thin as anyone wants. So you want to have a thin section so you can pick up all the areas. The best technique, your TE and TR, those are MRI physics things. And then actually Siemens, so there's, you know, Philips, GE, and Siemens are the big manufacturers of MRI machines. And the Siemens has a patent on a sequence, and I have no relationship to Siemens, by the way, just so you guys know. But Siemens is better, SWI is better than the rest of them, and because of it's from Michigan, and there's a whole story behind it. But here's a case where they had on the GE, there was a subtle hemorrhage here in the right frontal lobe superiorly, and on the Siemens SWI, it was actually seen a lot better. And now this is not as dramatic. I don't want to mislead people. It's not like every TBI case needs to have Siemens. I don't think that's true. I don't recommend that. And it's not as big as difference. I mean, GRE to SWI is like 4 to 6 times more hemorrhages. With Siemens, you may get, you know, maybe out of 100 cases, you may have a couple that you may be more confident in on the Siemens. So that's the difference.
Dr. Snyder, can I ask you a quick question about the previous slide? So, you know, when you're talking about SWI and kind of these things that you should check off, I mean, are most imaging centers or radiologists or neuroradiologists going to default to this when they see head trauma, or is it something, you know, specific to SimonMed, you know, and for the people who might not be, like I said, in the metropolitan areas, you know, how do they get something like this?
Well, a lot of places nowadays do have SWI. So SWI is certainly not specific for SimonMed. You can get that probably, I would say, big imaging centers around the country will probably have it. Hospitals have it, but sometimes they don't run it on traumas because it takes longer, and they're going through the ER and trying to look for life-threatening stuff. So I think it's becoming more used, and it should be, I think, in every trauma protocol. But sometimes people will just use they'll use the gradient echo, and they'll just try to look for stuff.
Understood.
Kyle, and from the attorney perspective, you're pretty much right. A lot of small centers, even if though they have the technology, they will not apply it to a read. So that's why when you get a client that you think might have a traumatic brain injury, even if you have already a CT scan or an MRI from somebody else, you want to work with somebody who can run all these sequences at a high quality level, because they might be able to uncover things that somebody else may have missed. I mean, just one clear example, I know Dr. Snyder is going to get to it later on, is him and I had a case in which the initial CT scan missed the injury. It was there. It was caught between slices. And he was rescanned at Dr. Snyder's facility, and Dr. Snyder went back and looked at the original CT scan and said, it's right there. It was caught between slices. We're then able to go back to that radiologist, show him the slides, and he actually amended his medical record and went back. And then we were able to get a new certified medical record and use that to prove our injury from day one.
Well, thanks, Hugo. Yeah, that was a good case that I think, we're going to show that case. So that was an interesting one. So the other thing with SWI that you can do besides, using thin section and if it's available, the Siemens SWI, is this 3D technique. And 3D SWI, what it does is it makes everything into a cartoon and increase differences increases the differences that are seen on the scan and kind of blows them up. So here's the case where there's a right frontal trauma, and then the 3D SWI sort of makes it bigger and you can see it better. So the way that I use these, it actually enhanced detection, because you look at the 3D afterwards, and then you can go, and then if you see something, you can go back and look at the conventional imaging and make sure it's there. So you can't diagnose it from the 3D, but you can use the 3D to go back and see if it was there on the original. And it's also very illustrative for juries, because it looks, the whole image looks kind of cleaner. If you have this, it looks. So I think the 3D SWI is another part of the SWI protocol, which can be quite helpful. So now so why thin section triplane FLAIR/T2 imaging? And this is an example here of a FLAIR sequence, axial. And there's a very subtle contusion here in the left frontal lobe. There's encephalomalacia gliosis, and we can see that it's matched up over on the other side as well on the coronal. So and I'm picking the slice, it looks obvious here, but this was only on like one slice, and this is a very thin section. So if you don't have thin section, you could easily skip over that. So here's another example of a very subtle inferior temporal contusion, seen only on the coronal plane and only on 2 slices. And these slices are 2 millimeters thick. Most coronal slices are typically 5 millimeters thick. So it could easily skip this, and it goes from a contusion in the temporal lobe with to a negative read, basically. And so this shows the inferior temporal contusion. And this is a common place where, because the brain grates against the skull when it's jostled, that's why you get the contusions here, and also in the anterior inferior frontal lobes. So you have, if you look right where trauma is most common, then you have a better shot to pick it up. Another example of this is where we're talking about the anterior inferior frontal lobes near the skull base, very commonly placed to have traumatic brain injury. This is the frontal gyrus. And you see these areas of T2 signal here. That's where they had the contusion. The axial matches it very nicely. And so it's but this is, I mean, these images I'm selecting for this slide, if you go above or below it on these slices, they're really not seen very well. maybe the most subtle contusion that I've seen. Here is the axial slice showing this little area of volume loss here in the very characteristic location for trauma, but very small size. And the T1 actually showed it probably the best, and it shows that little gap there. So it's a small contusion in that area. So that's the reason to do those sequences. So this is the case that Hugo was talking about before. And I wasn't sure how to present this, but this is the later scan. So the patient had an earlier MRI, and this was the follow-up. And you see this injury, this focus of increased T2 flare-weighted signal in the left superior frontal lobe, subcortical location on the left here. And then you see on axial, so it's on two planes. It's not artifact. It's very clear that's where it was. This is with thin section imaging. Now, if you go back to the earlier scan, and hopefully this is projecting well, but you sort of see it on the coronal here, but the green, the central green line shows where this axial image is. So it's actually above the slice on this image. And you see there's nothing there because it's above it. So when you scroll down, you go one down, you get to this axial image. And now you're over here, you're below it. So the axial image went above it and below it, and the lesion was right in between these two axial images because thin section was not used. And so when they did the follow-up MRI, then it was clear that that was there, and this played a role in this particular case as Hugo was discussing.
No. Dr. Snyder, if you're okay with it, I think we got Haley. I think there's like a handful of questions that are kind of building up. So maybe we take about 5 minutes and run through these real quick if you're okay with it.
Sure.
Fine, Dr. Snyder, you ready?
Yeah.
Okay. How is traumatic atrophy distinguished from degenerative or due to simple aging?
Well, it's so yes, that's a good question, and I'll show some graphs later that may answer that, which kind of show what there's some graphs that show the normal progressive aging, and then it'll show accelerated atrophy near the time of the trauma, which will then stabilize over time. So to get that, you have to have multiple scans, and the best would be if you have a scan before the trauma. So if you scan before the trauma, you have a scan after the trauma, and it shows atrophy, or if you have many data points for these scans, then you can basically exclude that. I mean, in the unlikely event the patient developed a neurodegenerative condition immediately at the time of the trauma, but then those often progress. So the degenerative conditions will progress. They won't stabilize. In some cases, there may be a differential. Maybe there are maybe some cases where you're not sure if it's from the trauma or a neurodegenerative condition, but then also, is it coincidental that someone developed, some kind of condition like that right at the time of the trauma? It seems, quite unusual.
What is the range of volume loss you would expect from a minor TBI injury?
Well, the range is, we've seen fairly dramatic to subtle, and I'll show later on in the lecture, I'll show examples of both. Or, you don't have to have trauma either. You can have MTBI and have no atrophy. It doesn't mean that there wasn't, trauma or, symptoms. So there's a big range.
And we've gotten a lot of different variations of this question, but what is the best timeline for each of the images? In other words, when should the imaging be taken for the 3T, the SWI, the DTI, etc.?
Yeah, I get that question all the time, and we'll talk. I talk about that later in this lecture. But it's best to image close to trauma, and then it's also good to image further from trauma. And it's good to image close for the contusions and the hemorrhages and the shearing injuries, and it's good to image further because of the atrophy. So ideally, you could do both. Sometimes it's not possible, but that's the ideal situation.
Is neuropsych testing and patient history used to correlate the imaging to the symptoms? What is the role of the neurologist?
Yes. So a lot of times, and I've kind of trying to figure out the role of the radiologist in this. If I get too into clinical symptoms of the specific patient, I kind of get attacked, and in some sense, rightfully so, because I don't see patients. I'm not a neurologist. I don't do neurologic exams. So as a radiologist, I talk about the functions of the parts of the brains that are imaged. I talk about prognosis. For example, we saw the subarachnoid hemorrhage and the subdural prognoses that were in the slides. So talk about how those are poor outcomes. There's many imaging findings that are associated with poor outcomes. And in some cases, I've gotten into it where it's quite obvious that the patient has some symptoms, and I can review some limited medical records. But a lot of times, it's kind of best if there's someone, neurologist or neuropsych, or someone that has worked with the patient, who can then take the imaging findings and say, okay, he has imaging finding that says it's poor prognosis. He has damage to this area, and I've seen the patient, I've examined the patient, I've reviewed the record, and he has deficits that are related to that. For me to do that, it can be done, but it's not optimal in I think in many circumstances.
And Hali, from the lawyer perspective on that, it goes back to what we've always talked about, that it's a clinical diagnosis. You want to have a neurologist or a physiatrist give you a diagnosis. Neuroimaging, like neuropsych testing, are tools which the neurologist uses to correlate everything. Normally what we'll do is we'll give the neurologist or the physiatrist, the neuroimaging, the neuropsych testing, and then let them put it all together. And after that, they can have a conference call with Dr. Snyder or with the neuropsychologist so that everybody understands how it all interrelates together. But traditionally, we want to use them as tools. You're not going to get your full diagnosis just from the MRI imaging. And that's where people get attacked a lot.
Yeah, so sometimes those calls are very helpful when when I'm on a call with other physicians and we kind of talk about what they think is significant, and you can really learn a lot.
I think this next question may be able to be answered by all three of you from different perspectives, but someone writes, there has to be a diagnostic cost balance analysis by the lawyer. What symptoms should the client patient demonstrate to determine when there should be enhanced diagnostics like a 3D SWI protocol?
You want me to go first?
Well, that's a tough question. Yeah, you guys go ahead while I stew on that one.
Sure.
So there's got to be, first of all, a medical requirement to do this. A lot of lawyers like to run and get their own scans. I, from a presentation perspective, think it's better if it's ordered by a physician. So I normally let the physician let me know when it's time to do this. Normally you have a collection of symptoms. The most common are dizziness, blurred vision, memory loss, things of that nature. This is where meeting with a client early on and documenting where they are is going to pay off. And I'll tell you one thing from experience, the more a client calls you with the same question over and over and just doesn't get it, there's probably something wrong with his memory. Don't get angry, look into getting a scan. And that's when you work with a neurologist and the physiatrist and say, okay, so we have somebody who came to you because their symptoms haven't resolved. And most neurologists and physiatrists are going to say, okay, well, I'm going to need to order some testing so I can rule out and rule things in. And that is when you make the decision based on whatever happened, if you have an ER record, or if you don't have an ER record, or the incident, how it happened, or whatever the family is telling you. That is when you decide. And also, I mean, really, you got to look at what liability looks like and what the coverage is on insurance or a deep pocket to even be able to move forward on these things, because they're not cheap.
Well, and that's what I was going to hit on is depending on where you're at, and we keep talking about clients that live in metropolitan areas. I mean, with big imaging centers, I mean, you could see some of this advanced neuroimaging that climbs the ladder of $10, $12,000 per scan, and has that. Do they have the mindset database? Are they doing neuroquantitative analysis? Every place does it a little bit differently, and that provides fluctuation for the cost. And so I think that that's something that has to be considered. And like Hugo said, when you're looking at these things, if you've got a 25-50 minimum policy for the defendant, it might not be optimal or feasible to run something like this, even though it could be a smoking gun in your case. The resources just aren't there. So I think that all has to be taken into consideration.
Yeah, I think if you have a low insurance limits policy, sometimes you do better just sticking with the neurologist and the clinical diagnosis, because some of this imaging does get expensive. Now, when you have the right case that has the damages, that has the coverage, and you have all these clinical signs and symptoms, I mean, that's when I really pick up the phone and call Kyle and say, hey, we're going to spend your money right now. And then I call Dr. Snyder and say, Dr. Snyder, we need your help.
That's right. That's right.
Well, from our perspective, I mean, it's always best when there's a clear mechanism of injury and there's clear symptoms following it and everything is documented, and it protects us as well when we're interpreting these scans. It gives us more confidence. And if cases are kind of sent willy-nilly or whatever, then it really is not helpful for us.
Dr. Snyder, do you or your team review MRI, CT scans, or CT scans already taken in cases where too much time has passed to do new scans?
Yes, I mean, because you can review scans done anytime, and a lot of imaging findings are there permanently because damage is permanent. So, I mean, sometimes I've reviewed scans that are done 5 years or more than that after the trauma. Or sometimes you can even see when a person was a kid and you see the findings when they're an adult. So there's never really a reason, to not to do it. It's just what we're talking about before is just the optimal times, but any time would be worth it if it's strong symptoms and mechanism.
What areas of the brain have higher correlation between TBI and personality change?
That's mostly considered the frontal lobes is sort of where personality exists in the brain, if you want to describe it like that, or that's where inhibition is. That's where a lot of executive decisions are in the frontal lobes. So that would be probably a commonplace. Emotions are in the limbic system, which includes hippocampus and temporal. So if that's damaged, I mean, that may also cause what could be construed as a personality change or just a global injury. I mean, sometimes it's not known what areas in the brain cause different findings, different things.
And this is the last question we have for now that'll get us caught up. But the client has negative MRI at the ER. Client has symptoms consistent with a head injury, clinically diagnosed with a head injury by physiatrist and a PCP 2 to 3 weeks post motor vehicle accident. Physiatrist orders additional MRI 2 to 3 weeks post motor vehicle accident, which shows a small bleeding. What are your thoughts?
Which shows a small bleed. I mean, I'd like to see what type of bleed it was, where the bleed was, because that certainly would be, I mean, any kind of type of bleeding on MRI, especially in a younger patient, really, there's not really differential for bleeding in the brain. If it's an old patient and it's in the basal ganglia, then that could be from hypertension. But if it's in a subcortical location or it's in any of the typical locations for trauma, then that would be more likely probably from a trauma. But I mean, we have to see what exactly the bleed was and where it was to kind of fully answer that. But just because, as we said before, just because MRI is negative doesn't mean they didn't have traumatic brain injury. Only 27% of patients have imaging findings with mild traumatic brain injury without the advanced imaging. I think we're a little more sensitive than that with the advanced imaging. All right, so we're talking about now just briefly. Perfusion is a type of advanced imaging that's done. And I put this here because we're talking about contusions. And so one of the value of perfusions is showing, this is an arterial spin labeling, is showing that this is the contusion on the flare. So here's the post-traumatic contusion. There's the gliosis around it. And what's interesting about it is the perfusion shows the defect goes all the way down to the ventricle. So someone could say, well, they had a contusion, but it was only pretty small, involving the anterior frontal lobe. But by perfusion, you can see that almost the entire anterior frontal lobe is affected by the contusion. So I think that's an important, probably the main value of perfusion. Now, if you do perfusion image early, you can pick up some asymmetries, which has been described, which most literature says that those typically resolve on the follow-up exams, but we have seen some cases where there seems to be perfusion deficit even in more chronic TBI cases. And this was a very interesting case where we had a perfusion which showed some defects here in the back of the parietal lobe bilaterally. And the patient had a PET exam, which we're not going to talk about in this lecture, but this is from a sugar uptake showing decreased uptake in the back of the brain, which matched this. So this was a very nice, so this was a young patient, no real reason to have any kind of PET deficits or perfusion deficits. And here's an article that talks about how FDG PET can be used in traumatic brain injury. But it's nice when things match. That's something that is, I really look for on all the imaging, is when different modalities match the same region. It gives you strength and confidence in where you may not have it only with one of them.
If the imaging reveals a mild traumatic brain injury, can the mild traumatic brain injury be dated?
It depends on what the imaging shows. So if it's volumetrics and you have serial scans, you can roughly date it. If you have the shearing injuries and contusions, you cannot date by imaging. So, but a lot of times that's not really. The more that I've kind of been working with traumatic brain injury and our research and stuff, I mean, a lot of times it's really not. That's not really an issue because it's quite obvious that this head trauma that we're seeing is probably from the worst head trauma they had in their life, and the worst trauma they had in their life is almost invariably, or a lot of times, what is in litigation. Now, if they had a head trauma, younger and it was pretty bad, then I don't know if it's worth to even get. It may not be worth if someone had a significant head trauma at a certain age, then. Or there's a history of fractures or bleeds, then I mean I'm not sure unless if we have comparative images that would help, but otherwise it may not even be worth the image because you're going to be you won't be able to separate what trauma it's from. So here are imaging findings which are highly specific, and we're trying to move a little faster. I think we're kind of running a little behind here, but. So the fractures are specific, contusions, hemorrhagic diffuse axonal injury, and these are all images showing fractures with the nice CT reconstructions, hemorrhages and severe frontal lobe injury in this patient, and also temporal lobe injuries, and these are common locations for head trauma. So imaging highly specific for head trauma is diffuse axonal injury, and these are some articles in the literature where it was actually, it was not a severe burden, it was a couple of foci. So if you see those, it's helpful. This was a literature case where there's just one foci here, but it's right at the groin-matter junction. So that would be consistent with the history of head trauma. And these are the articles that talk about kind of more subtle hemorrhagic diffuse axonal injury. And these are just some examples of what it looks like on SWI. And then here it is on another patient, SWI, showing these kind of linear areas in the parietal lobe here. And this is another one. And this is another case. It looks the same. These little black dots in the brain, hemorrhagic diffuse axonal injury. And this is kind of the tip of the iceberg. There's probably more injuries that are below this that we're just not picking up on the MRI. This is just a severe case. And it's a severe case when you can't even draw arrows. There's too many lesions, so you have to draw circles. Unfortunately, for this patient, this is a devastating injury where they have just these clusters of hemorrhages all over the brain, everywhere in the brain, midbrain, all the way up here in the top and all the way through the brain. So that was just a absolutely terrible case of global brain injury. So this is an important slide because instead of you could describe hemorrhagic diffuse axonal injury as we saw in the last couple of cases and just say period. But I think radiologists should be doing a little more than that and to talk about the overall burden. So there's articles that talk about small burden, moderate, severe burden, and those correlate with prognosis. So if there's a moderate or severe burden, it's worth to put in the report that this patient has a poor prognostic outlook based on the literature imaging. Also, hemorrhages that involve the corpus callosum, those have poor prognostic with the studies done. Also the brainstem and the midbrain. And these are two areas that are kind of like the mammalian deep part of the brain where it's involved with a lot of like subtle functions like respiration and cranial nerves and stuff, not really high level thinking, but those areas have a poor prognostic finding. So here's a case where there's probably in the body of the corpus callosum, there's some subtle hemorrhages. So those are worth mentioning in a separate line, talking about prognostic. Here's the left midbrain showing these hemorrhages in the left midbrain, not present on the right. This is the cortical spinal tract runs through here, so they might have motor deficits, but it's a poor prognostic sign. And these are the articles that talk about it. So here's a case of, you can see this patient had a frontal contusion here with all these hemorrhages here, but look at these tiny little dots in the corpus callosum. This is the corpus callosum here. It's called the genu of the corpus callosum. So these tiny dots are hemorrhagic diffuse axonal injury of the corpus callosum, which is the biggest fiber tract of the brain. And without it, the left and right hemisphere basically can't communicate. And so this is sort of a cartoon showing where this injury is on the side view of the corpus callosum, which is the biggest fiber tract in the brain. And this is the article that talks about it, how it's a poor prognosis when you involve those regions. So I always look for that. And if I see it, mention it in this way because it's scientific, it has a prognostic implication. So here's now a different case where this is an axial SWI image showing these little hemorrhages, microhemorrhages in the back of the corpus callosum. So the first case we saw the front, now we're seeing the back of the corpus callosum. So here's just a side view of the patient, and this red is not from the image. I put that there just to show the injury. So that's the red where the injury was. And then here's the cartoon showing us now in the back of the brain, the splenium. And so this is, again, the importance of diagnosing. So this is the question someone raised before is when to image. And the answer is unequivocally, in my opinion, early. Because of this, and the reason because of these three facts, basically, that 70% of hemorrhagic diffuse axonal neural injury resolves on follow-up MRI. So if you image at the time of the trauma in the emergency room, about 70% of these, according to this article, will resolve on follow-up. So that's why there's no reason to wait. 30% of non-hemorrhagic shearing injuries, so those are shearing injuries without hemorrhage, resolve. And then 30% of contusions actually resolve on the subsequent MRI. And then there's a volume reduction of 44% on average 1 year following the trauma. It doesn't mean the brain has healed because the brain doesn't heal. It just means that there's some, the macrophages or at the microscopic level that some of the scarring sort of evolves in a way that you don't see it. So, if you image too far late, you'll still see it. And the ones that stay, by the way, after 6 months or a year are there permanently. So you'll see them forever. But in that early part of it, you'll see in the first year or 6 months, you'll see, or maybe even earlier, you'll see a lot of these very classic imaging findings for TBI will resolve. So we'll move kind of fast through this because this is, but imaging findings that are possibly related to the history of head trauma. So there's, I included 5 here in this category, and we'll just kind of briefly go through them. Empty sella is the pituitary gland here. So this is a small empty sella, and that can be seen incidentally, or it can be seen in patients with endocrine disorders. But also in head trauma, there's about, I believe it's about 20% of patients can have endocrine disorders following head trauma. And this is described in these articles. And so that may correlate with a empty sella. I've seen cases where the sella was prominent and then following the head trauma, it decreased in size. Even if it's just a little, there's no reason for someone's sella to decrease. This is a normal showing the pituitary gland. Cavum septum pellucidum is a structure that this is kind of the normal over here on the left, showing the cavum septum pellucidum. And then a very small is when it splits, it's called a cavum septum. And then here's a larger where it kind of goes all the way down, cavum septum. And I read a lot of the, for example, in Vegas, before you box or fight MMA, you have to have an MRI. And because I'm specialized in trauma, I pretty much read all those. And I definitely have noticed increased incidence of cavum septum in those boxers. It's been described in those NFL players with CTE. It's been described in other things for traumatic brain injury. The problem is that it can also be seen incidentally. So if you image it, it can be seen in patients who have no history of head trauma. So it's not something you can oftentimes definitively relate to trauma, but you can talk about it. And these are some of the articles that go over that. So Chiari-1 malformation, it's when the cerebellum is in the back of the brain and the tonsils come down, and you draw the line from the opticyon to the bastion. And if it goes below that, below 6 millimeters, it's a Chiari malformation. They're not unusual to see these, and patients often have headaches and symptoms, even without trauma. And this is what a normal one looks like, where it's kind of right at the level. So, but the issue with trauma in this is that these articles talk about how patients that were not symptomatic from their Chiari became symptomatic following the trauma. It also talks about how there's radiographic progression, where actually you'll see on imaging that these tonsils will go down following the trauma. So in some cases, it can be a significant finding based on the clinical presentation Aneurysms. So brain aneurysm is when there's an injury to the vessel and it causes this saccular appearance. So those have certainly been described following head trauma. Here is the article on it. But there is a certain percentage of the population that has these normal. So it's some cases it can be tough to say if it's from trauma or not, but because you can see them also in asymptomatic normal patients. Perivascular spaces, these are little areas in the certain areas of the brain that dilate. So you can see them in the basal ganglia, which is almost always normal. I would never say that these are related to head trauma in the basal ganglia. I mean, it's possible, but it's more likely it's just a normal variant. You can also see them sometimes in the vertex like this. It depends on the size and morphology. But you can see them next to shearing injuries. Like in these cases here, there was shearing injuries and these dilated perivascular spaces came up. And so this is the article that talks about this. And so dilated perivascular spaces are possibly related to head trauma, depending on a lot of other factors, but they can also be seen as normal. So any questions on that? Are we ready to get into the?
I did want to ask Hugo something. Is it as we touched on? Like you said, when to image. I think we get a lot of questions about kind of what that specific timeline comes in from, maybe somebody coming into your office and exhibiting certain symptoms to the time you get to somebody like Dr. Snyder and, imaging like this. I don't know if that's something that you could kind of, articulate a little bit more about how that process typically works for you in your practice, seeing that you see a lot of these types of cases.
Yeah, well, this is just the ideal, and we see patients that come in all different times, and there's really never, there's not really a reason. If you don't image them early, it's not like you're not going to find anything, or doesn't mean they weren't injured. This is just the ideal time. So we see patients that are scanned anywhere from 2 days following trauma to 8 years. It really just depends on a lot of stuff that's going on clinically that we're not privy to. So we see it all over the map, but when I interpret an image, I definitely look to see the date of the trauma in question, or if there is histories of prior traumas or anything, because it may sort of alter how you dictate your findings. For example, if I get a case that comes in within like a week of the trauma, or 2 weeks, then oftentimes I'll put in my report, or even with a couple of months, I'll say that volumetric findings, follow-up exam might be worth to get to look at the to assess for interval atrophy. Now, if the patient is imaged like 5 years after trauma, I probably won't put that in my report, because a follow-up scan, unless they have some kind of CTE or progressive degenerative change from the trauma, is probably not going to be much help. So,
gotcha.
Dr. Snyder, are upright or open imaging an option for people who have claustrophobia?
Yeah, so there's a couple options for those. We have actually at our center here in Nevada, we have an open magnet, which is only it's only 0.6 Tesla, so the quality is not great, but it's of course better than nothing. And they actually just sit in a chair and they just watch TV while they're in the magnet. So, they kind of like it, but the image quality is not great. We also there's different types of bores. So there's a wide bore. We have one of our centers here. In Florida, we have a couple. California, Colorado, we have them as well. So the patient may have to travel a little bit to get the open bore, but it gives you an extra like 3 inches, which sometimes can make a difference for people not with severe claustrophobia. And sometimes the doctors can prescribe a sedative, like they can give them and we don't do that at our centers, but preferring doctor could give him or her a Xanax to take before they go in if they can.
Other than the literature you mentioned in a previous slide, do you have any recommendations for specific journals, books, or other things that will assist lawyers in discerning the information you've discussed today and communicating with you, the doctor, and later a jury?
Oh, that's a great question. I'm happy to, as I said, share this slideshow with anyone here. But as far as everything being in one place, I'm not sure that exists. You can look through some of the some of the medical literature on this stuff. There's like review articles that talk about it. Of course, I'm privy to our article, which is I'll show later on, but it's the Veneer 2020 article, which really has a lot of this in there. Another great resource is, I don't know if you all know Dr. Bigler. He has written some really good articles. He's just extremely scientific and extremely smart guy who has pioneered a lot of the research in traumatic brain injury. And if you read some of his articles, they're very well written, and they summarize some of these things quite well.
Thank you.
All right, great. So now, we'll go through this. So these are the findings more likely or not related to head trauma. This is kind of the most interesting part, I think, personally, of this lecture, because there's some debate over some of these things. Everything we've said so far, hopefully, at least, I wouldn't debate, or I think that's very well. There's no difference of opinion. These topics, there can be differences of opinion. So I know we have talked about a lot about atrophy. So atrophy related to head trauma. So one atrophy is global atrophy. So here was a case where there's trauma here. You can see hemorrhages actually around the brain, and these are the ventricles, and the lateral ventricles are fluid-filled spaces in the center of the brain. So this was initial CT, and then here you have the MRI, which is a couple years after, and you can see how large these are. And the ventricles are large because the brain surrounding them has died, and so the ventricles fill in the space. And it's a very poor prognostic finding. So this is a global atrophy from head trauma. So it's not just these frontal contusions or this temporal contusion. There's a global brain injury here. And these are the articles that talk about it. And post-traumatic ventricular enlargement indicates diffuse brain injury, and the lateral ventricle size is the best predictor of cognitive outcome. And these studies found that it was even more significant predictor than the severity of the original trauma. So if someone had like a severe blow to the brain, or maybe not as severe, that the lateral ventricle size in these patients that had trauma were more prognostic of cognition. And these are the articles talking about that. So this was a great case. We're talking about this before. This is maybe one of the most subtle cases. And this case actually went to trial. And this was MVC was a day before this. So he had the MVC and he went to the emergency room at this time. And you can see the lateral ventricles here. The arrows are pointing to them. These fluid structures, they're that size. And so then 2 years later, in 2011, they had gotten bigger. And so that is a kind of a interesting finding. And then if you go to, so then 7 years after this, after 2 years after the trauma, they're pretty much about the same, maybe a little bigger. So the difference is here between these two scans, and it's fairly subtle. And you couldn't make the diagnosis from this CT alone. You had to have all of these. But that degree, and then the stabilization, is what we see in post-traumatic atrophy. So we can actually graph this. And this is that case, how we graphed it, where the trauma was here, and we saw the ventricles become dilated, and then it kind of stabilized over time. This is the centimeters cubed. So we traced them to get areas, and then we calculated the volume of those ventricles. And anticipated is from this author, Scahill, and it shows how the ventricles get bigger with age. As we age, our ventricles just naturally get slightly bigger every year, and so this guy had a spike, which was certainly, I think, likely from the trauma. And this wasn't the only finding. There's other things in the case that were, supported this, but it was a pretty subtle finding that was quite important because of the correlation with cognition. And this is just how you can trace these to get exact volumes. As you can trace the, trace the ventricles this way, or you can sort of trace them and get these volumes. You can also trace the corpus callosum volume. So you put a cursor around it, get an area of this, and you do it on a few slices, you get a volume of the corpus callosum. And I had a case, actually I do quite a bit of carbon monoxide work too. And we had a very dramatic case where the corpus callosum got like 3 times as small following carbon monoxide. And as we saw, sorry?
Nothing, go ahead.
Sorry. As we saw, the corpus callosum is a structure that's really important for prognosis. So if you see it shrink like that, these are things you can do. And you don't, this is really for forensic purposes. I mean, in clinical practice, you can look at it, you can see it, but sometimes, people don't believe it, or they fight about it, or they say it's not true. And so when you trace this and you have a centimeters cubed at this point, centimeters cubed at this, then it's really not debatable. It just adds more science to the imaging findings. So this was a great case, and I think I worked, Hugo, with you on this case. This is one of the most this was a case that, and so that we actually, so these green are all CTs. This is all CTs done on this guy, and he actually had a pre-accident CT, which we don't normally get, but he had a pre-accident CT, and then he has trauma, and then around the time of the trauma, he had a CT, and then he had a CT, I guess it was 2 years later, and again, there was a spike in the lateral ventricle volumes. So it really is, and then we got the CT then a couple of years later, and he was still above the expected, but it wasn't, that dramatic. And that's the finding, the rapid increase following trauma and then stabilization. And so I think this was going to the question people asked before about, can you date trauma? If you have a case like this where you have all these data points, it becomes possible for actually the neuroradiologist to give some insight into when the trauma occurred, or is very consistent. And the other, neurodegenerative process. Someone was talking about, was there any way a neurodegenerative process could look like this? I think the answer would be no. Neurodegenerative processes, they accelerate atrophy. I agree, but then this data point would be way up here. I mean, it keeps going up, and it can go up quite significantly.
And Dr. Snyder, you can go back to that last slide. Something interesting about that case was that the person had a subsequent motor vehicle accident. And we actually used your graph to actually date the traumatic brain injury to the incident that was the base of litigation, because it was a subsequent accident which they were trying to blame as having caused all the symptoms.
Oh, that's right. Yeah. And I think that trauma was somewhere around here. Is that right? Uh-huh. Yeah, and so, and that was, so I had forgotten that, but yeah, and so I think we said was that, maybe this increase is, maybe some of this is due to the, the more recent trauma, or maybe it's from this trauma. So, we weren't sure about this, but we said this was due to the trauma in question, right? Yeah, so that was interesting. All right, so hippocampal atrophy. And hippocampal atrophy is hippocampus is an area that's commonly injured in head trauma because it's kind of dangling here at the bottom of the base. And as we mentioned, Dr. Bigler pioneered a lot of that, other people as well. And this is, the arrows are pointing to the hippocampus of a patient who had a pretty severe atrophy. And this is a normal. So you should have these normals being nice filled space of the hippocampus. And so every case, I look at the hippocampus, and then also our volumetric software looks at it, because it's been implicated in a lot of clinical conditions, actually including Alzheimer's disease, seizures or other causes. So it's not, 100% specific for trauma, but young patients, you are better off with it, or better with it, I should say. So here's a case, and it doesn't necessarily have to be, severe atrophy, but this is the Neuroquant looks at this as well. And this patient was in the 98th percentile, which is actually big. And the right was in the 56th percentile, which is above average. But even though it's above average, this asymmetry is still so significant that it would be, consistent with the history of trauma in the appropriate setting, because it's so far off the charts in the 99th percentile by asymmetry.
Doc, I wanted to ask you, and maybe you might be addressing this a little bit later, but you touched on the Neuroquant right there, and if I'm jumping the gun, you can just say, hey, I'm gonna get to it. But I would like to get both you and Hugo's opinion about the Neuroquant analysis and how that plays into a lot of people who might be listening in who are going to do this kind of imaging, and what it means. And Hugo, for somebody like you, how do you use a tool like that to kind of explain to a jury this is what's going on?
All right, so I can go first on that one. The Neuroquant, to me, it's helpful if you have a volumetric kind of presentation. So it goes back to, you have a whole host of tools you can use with neuroimaging, and you have to sit down and figure out which is the best one that proves your injury. Sometimes the SWI sequence will be the best one. Sometimes it's the volumetrics. In fact, Dr. Snyder and I have a case in which the DTI is nothing spectacular, but the volumetrics are fantastic for the case. They really show the level of injury. In that kind of instance, we would use something like Neuroquant, which it's a software that basically calculates volume loss.
Yeah. So it's a software that it calculates volume loss as compared to a normal database. And actually, we just had an abstract accepted into the RSNA, Radiology Society of North America. It's the biggest radiology conference pretty much in the country. And what we did was we matched our trauma database to Neuroquant's normal database. We found some very interesting findings. So that'll be coming out in December, that abstract, and we're going to hopefully turn it into a paper. But Neuroquant is helpful, especially if it matches the subjective view of the radiologist. I think it is accurate. I wouldn't say it's 100% accurate. There is some technical factors, or there's some. I mean, it's still an evolving science, but I think it is fairly accurate in looking at volumetrics as compared to, it matches the patient to hundreds of people that are roughly the same age and sex, and then it gives you z-scores or standard deviations. And so I think it is certainly roughly accurate and useful in diagnosing TBI, especially when combined with other findings.
I mean, I will caution everybody that it's not a silver bullet. Dr. Snyder and I have had cases where Neuroquant came back perfectly normal, yet the DTI showed a severe injury. So again, you have to decide, out of all the neuroimaging tools, which is the best one for your case.
Sure.
Yeah. And just because Neuroquant is normal doesn't mean the patient didn't have head trauma, because a lot of times you don't know where the patient was. So like in this case, say this left hippocampus was in the 98th percentile, and then following the trauma, they're in the 56th percentile. If you start above average, it's kind of like neuropsych testing. If you have a very high functioning person and now they're average, someone could say, well, they're average, they're fine, but you don't know where they were. So some of these volumes, you don't have the pre-trauma scan. And so I certainly think we're missing pathology because we just don't know where the patient was before. And there is individual variation in brain volumes to some extent.
Good point.
We are almost out of time, but we do have one more question, Dr. Snyder, and that is imaging for atrophy appropriate sooner than 6 months post-accident causing the mild TBI injury?
I'm sorry, can you repeat that? Is it?
Yes. Is imaging for atrophy appropriate sooner than 6 months post-accident causing the mild TBI injury?
Yes, because the atrophy will start to accelerate within 2 weeks of the trauma is when it begins, and then it will probably peak by about 2 or 3 months, and then it will still be coming at 6 months. So anytime in there, or even if you can create multiple scans, then you would be able to pick it up. And so this was another case of a patient had a traumatic temporal contusion here on the left and hippocampal atrophy compared to a normal. And when we graphed, this is a different case we had. This is from Neuroquant. We graphed hippocampal volumes. So they had 3 different MRI scans, and we saw the steep decline following the trauma. And then it kind of stabilized over time, which is an expected pattern that you see with trauma. And the normal percentiles followed this. This was a case I was involved with in Florida, and it really showed this nicely. So I guess we'll move kind of faster. We're almost out of time, Hali, or what's our time limit? We're almost.
We're at 4:30, but if you want to go a few more minutes to hit any more important points, and then I think Ginger was going to jump back on.
Okay, we'll just go real fast in here. So a cortical volume also is the outside of the brain, and this was a case showing the bad cortical volume loss. So when to image early and late, we've talked about that. White matter hyperintensities, you can see with many conditions, including shearing injuries. And this is the non-hemorrhagic shearing article, talks about how you don't have to have hemorrhages to have shearing. And
Dr. Snyder, can you explain a bit better what is actually a shearing injury? Because
so shearing injury is when the brain, the outside of the brain is the cortex and inside is the white matter, and when they move, you get a shearing injury or a white matter hyperintensity, at the gray white matter junction, and it can be hemorrhagic or non-hemorrhagic. There's 2 types of shearing injuries.
Thank you.
Okay, so I think we kind of maybe talk about that another time. So diffusion attention image, I wanted to get into this, and that's the basically technique of it. And you can measure FA values, which is how you look at the corpus callosum in this case. FA values are the numerical numbers that relate to diffuser temperature imaging. And you got all these fiber tracks. So this is a normal three-dimensional reconstruction of DTI, and this is a case of multiple sclerosis, which is pretty bad. Here we had a trauma case.
Can I jump in for a second?
Yeah.
Because for the attorneys in the audience, DTI, as you can see, the imaging is profound. If it works for your case, it will really guide a jury into a finding of traumatic brain injury in your favor. However, that is where the biggest fight is always going to be on evidentiary issues.
Yeah, yeah. So this is a three-dimensional reconstruction of the fiber tract, and you can see here's a hemorrhage, which is right in the same location as the fiber tract disruption, and here's a non-hemorrhagic shearing injury also, which matches. So when these DTI matches a conventional imaging finding, it's very helpful. Spectroscopy also matched in this particular case with the anterior spectroscopy. This is a great case, unfortunate case of bilateral frontal contusions, and you can see the frontal part of the DTI is really torn up because of those contusions, so it can show it quite nicely. Another case of a severe trauma here, and then there's DTI matches the conventional imaging. And it's another example of it. So should we come back to this if we have time, or Hugo, what do you think?
I think what I mean, it's a good thing because we had so many, questions and everybody was so engaged, but it might be something where we might have a part two. And
that's what Ginger and I just said. We need a part two.
Have another talk about, really getting into the meat of diffuse tensor imaging and some of the things that weren't able to be, covered here. I don't want to do a disservice to everybody because I think you got a ton of good information here that I want everybody to get, and I really don't want you to have to rush through it. So, Ginger, that might be a good thought for the next couple of weeks.
Yeah, absolutely. I would love to schedule a part two because we're already getting such great questions. And a lot of times, I mean, that's what we're here for. They want to talk to you directly and ask you questions that they have. So I'm glad that we were able to take those. And if you're okay with it, I will definitely be more than happy to schedule a part two and we can continue this conversation. But I would like to jump real quickly. Is it okay that I close these slides real quick, Dr. Snyder?
Oh yeah, sure, yeah, and sorry we ran a little long there, but yeah, I think we do a part two would be great because we could spend a lot of time talking about just that one slide. So yeah.
Oh, yeah. Absolutely. I mean, there's just so much great information to cover, and it's so important to talk about this. So I'm all for doing another one of these. I am going to email this contact information to everybody. So that way you can just reach out to Dr. Snyder directly. You can reach out to Kyle, Hugo, Hali. They're more than happy to help. And I'm so excited. I mean, even with Keith and Paul and Kyle, thank you guys for sponsoring and doing such an amazing job today. I do want to go ahead though and bring Laura in real quick. She works with Strategic, and she is going to be sharing a special giveaway. So I'm glad everybody stuck with us because someone on here is going to win a $250 gift certificate towards their company. So that way they can try out one of these ex-employee lists and find out more information. So I'll wait for her. Hi, Laura. Thanks for being here.
Thank you so much for inviting us. What a great presentation.
Absolutely. And if you don't mind, how would you like to tell us who is the winner today and what they're going to win?
So yes, we looked thoroughly and we have the best winner for today's $250 certificate from Strategic Relationships that can be used within 2 weeks from today and could be also passed to another friend attorney if needed. And the name is Milton Eisenberg II. Congratulations.
Congratulations, Milton.
Very exciting.
This is awesome. So Laura and I, we can both reach out to Milton after this webinar and then make sure that you guys get connected. But this is such a wonderful giveaway. Thank you so much, Laura, for doing this.
Thank you.
And I'll make sure we got Paul's information that we shared, but if anybody wants to reach out to you as well, what's the best email? It's laura@strategic.com.
That's it. Or my cell phone at 404-931-8350. Day and night. Call me at any time.
Fantastic. Thank you again so much, Laura. And then now I want to bring it back to Kyle. because Kyle has got a special announcement as well. And I know everybody's been waiting for this because this coffee is getting around the country and somebody is going to win 4 bags of this freshly roasted coffee. So Kyle, if you could do us the pleasure of announcing that. And then again, thank you for doing this for us. We really appreciate it.
Yeah, no problem. Today's winner is Gary Roth with Roth and Associates in Houston, Texas.
Yay, go Gary. Congratulations. So we're going to reach out to him in just a little bit as well. That is a wonderful, I bet he's probably surprised. I have people that email me all the time that are like, I can't believe how good this coffee is. So thank you for sharing that, and congratulations to Gary.
Awesome.
And then now, again, I just want to thank all of our speakers. Thank you, Hali, for moderating this. Dr. Snyder, your presentation is outstanding. I will definitely make sure all the attendees get a copy of it, but also make sure that they follow up with you when they have extra questions. And then I'll make sure that we get a part 2 scheduled. Hugo, we definitely want you back. Like, this is great. Thank you so much.
Well, thanks. This was a lot of fun and really great questions from the audience as well. They were. I could tell that people were really focusing on the important stuff. So this was a lot of fun, and happy to do it again.
Absolutely. Does
Wonderful.
Kyle, anybody have any closing remarks?
Yeah, no, I mean, we just really want to thank everyone for tuning in. I mean, it was a huge attendance today. And so we know that we probably struck a nerve with a lot of people, and obviously we're excited to be part of this, ongoing series on TBI. So thank you to Connectionology for putting this on and giving us a platform to get this information out to everyone.
Absolutely. Thank you so much. We love working with HMR, and you guys are fantastic. And if anybody would like to watch more of our free webinars, please go to connectionology.com and you can stay tuned. And I have a very important announcement is I think we're going to try to get some CLE credits, some free CLE credits for all of our webinars moving forward for our plaintiff attorneys and paralegals. So stay tuned for that information. And again, I hope everybody has a wonderful afternoon. Thanks for joining us today.
Thank you,
Thanks, everybody. Stay safe.
Bye, everyone.